Welcome to our presentation on South Korea. South Korea is a country located in Asia. It became a country in 1948 when Korea was divided into North and South Korea following World War II. Geographically, South Korea's landmass is approximately 100,032 square kilometers and is located between the Yellow Sea and Eastern Sea. The land is filled with beautiful rivers and large numbers of successive mountain ranges that crisscross the peninsula. South Korea is approximately 1/100th the size of Canada, yet they have almost double the population. The current population of South Korea as of 2015 is approximately 50.3 million, with nearly an identical amount of women and men, and 90% of their population is located in urban areas. The capital of South Korea is Seoul, also known as a special city, and this is located in Gyeonggi-do. And South Korea is composed of 9 provinces, with Jeju, an island, being recognized as the special governing province. Now let's talk about the South Korean healthcare system. We are first going to discuss the overview of the healthcare system in South Korea. Then we'll give an analysis of their healthcare system, followed by the health status of the nations served. So let's not waste any time and just dive into the overview of the healthcare system. I invite you to come explore the historical roots of our healthcare system now. The Third Republic of Korea, under the Park Chung-hee administration, created the first elements of the Korean healthcare system. In 1963, they enacted the first health insurance law called the Medical Insurance Act, which allowed companies to purchase health insurance plans for their employees. Then in 1969, the Pusan Blue Cross Plan was established, which allowed people to purchase individual health plans. The Fourth Republic of Korea, still under the Park Chung-hee administration, announced the plans to create a universal health plan in Korea in 1976. The plan was enacted in 1977 and took 12 years to cover all citizens of South Korea. This process started with companies who had greater than 500 employees and slowly included more groups until all employed and self-employed citizens participated in the program. Following the assassination of Park Chung-hee, a new president, Choi Cho-ha, created the medical aid program in 1979 for low-income households, in which governments will pay for all medical expenses. Subsequently, in 1989, traditional medicine became formally incorporated into the healthcare system. In the year 2000, all health insurance societies were integrated into the National Health Insurance Program, aka the NHI. In 2004, under the Sixth Republic and Kim Dae-jung administration, the long-term care insurance program was introduced. The program covered the elderly with serious issues that included activities of daily living, providing them with medical services that included nursing, shopping, cleaning, baths, and laundry services. That year, the medical aid program was also expanded to cover patients with rare, intractable, or chronic diseases, and children under the ages of 18 years old. Korea's unique history, culture, and economic components have all highly influenced the development of South Korea's healthcare system. Now let's take a journey through Korea's history. It dates back to 2300 BC. During this time, it was highly influenced by Chinese culture, religion, philosophy, art, and traditional medicine. Now let's fast forward to 1910, where Korea is forcefully annexed by Japan until the end of World War II in 1945. During this time, Japan enforced cultural assimilation policies. For example, Korean language was banned and no longer taught in schools, and their traditional medicine was also banned while Western medicine was put into place. Then in the year 1919, the independence movement occurred, and there was a peaceful protest on March 1st, 1919. Unfortunately, it was not so peaceful. 2,000 were killed, but in response, Korean people became more tenacious in not permitting the loss of their traditional culture. Following Japan's defeat in 1945, Korea was split along the 38th parallel on August 8, 1945, to divide it into Soviet Russia, who occupied Korea, and American Korea as well. No Korean government was involved in this decisional split. In 1950, North Korea engaged in an unprovoked invasion of South Korea. The Korean War lasted until July of 1953, and during this time, a whopping 80% of industries, policies, public facilities, transportation systems in Korea were all destroyed. There was also a massive disintegration of traditional lifestyles, health and well-being of all Koreans because they were considered among the poorest in the world. In 1958, South Korea elected their first president, held their first democratic vote, and finally became an independent ruling country. So now let's talk about how Korean culture has influenced the healthcare system development. Korean is heavily influenced by Confucianism, Buddhism, and Taoism. Taoism and Koreans' belief that life and health relate to harmony and can be seen in South Korea's national flag. Now let's discuss a little bit about the South Korean flag. The flag was adopted on October 15th, 1949. The trigrams represent heaven, water, earth, and fire. The white field represents the Korean people as peaceful and purity. The yin-yang symbol represents unity and balance. The blue represents negative forces, and the red represents positive forces. So a quick joke now for you. What did South Koreans' flag say to North Koreans' flag? Nothing. They just waved. Buddhism has had a major influence on the population's beliefs about health, sickness, and death being a part of their life. Disharmony of natural forces or life forces of the body lead to illness, and thus treatment involves achieving a balance. Historically, healthcare is rooted in traditional medicine and herbal doctors. With that said, Western medicine coexists with traditional medicine in South Korea. People often use a combination of traditional and Western medicine to understand and treat their illnesses or diseases. The family is traditionally the most important part of Korean life. Families are traditionally involved in all health decisions regarding a family member. In delivering, diagnosing, or care for a family member, they're expected to be present to be part of their support group. Economic development is the final component that has influenced the development of South Korea's healthcare system. Korea has experienced rapid capital change, going from one of the poorest agrarian societies to a wealthy industrialized society within 50 years. In the 1950s, Korea was among the poorest countries in the world, and it's now the fourth largest economy in the world. Rising standards of living have been accompanied by major improvements in the availability of health care services, underpinned by the rapid expansion of health insurance coverage. As a result, citizens can receive some of the best and most up-to-date technological care. However, the rapid change has come with a price. There's an effect on either lack of policies or the enforcement of policies in relation to standards of care. We'll discuss these effects later on. So now let's talk about the stakeholders. The major stakeholders of the South Korean healthcare system include the government, the public, the healthcare providers, private insurance companies, business owners, licensing bodies, educational facilities, and students of the healthcare. Now let's talk about South Korea's mandate, mission, and vision in regards to healthcare. A mandate outlines the formal and informal requirements of an organization. South Korea's mandate is to provide universal health coverage. The country does this by covering a portion of the cost of care as well as health promotion. The portion the government pays for increases for those who cannot afford to pay partial payments. A mission clarifies the organization's purpose. South Korea's mission includes building social safety nets for a better tomorrow, taking a life course approach to healthy life, and supporting stable life after retirement. A vision clarifies how the organization wants to look and how it should act in the future to fulfill its mission. It communicates enthusiasm and provides an organization with something to aspire to. South Korea's vision is building a happy society for all. And what's not to love about happiness for all? Time to move on to Section 2, which includes an analysis of their healthcare system. How is South Korea's healthcare system classified, you might ask? Well, we will be classifying it according to Boehm's taxonomy. So what is this? Boehm's taxonomy of healthcare systems follows a deductive approach. This typology distinguishes between three core dimensions of the healthcare system: regulation, financing, and service provision. And it also discusses three types of actors, which includes the state, societal, and private. This results in 27 different possible combinations. However, there are only 10 logically plausible systems with 5 primary system types. Classifying healthcare systems based on these dimensions and actors will result in 5 primary healthcare system types, which include the National Health Service, the National Health Insurance, the Social Health Insurance, the Tastic Social Health Insurance, and the private health system. Using Boehm's taxonomy, the South Korean healthcare system is identified as an ambiguous classification on the basis that it combines universal access to healthcare through a state-administered single-payer and socially health insurance scheme with private provision. It has elements that make it a tastic system, but we believe that it's a national health insurance system due to the fact that there is a mandated tax-like contribution system based on government policy. Now let's explore the funding structure of South Korea's healthcare system. The Ministry of Health and Welfare entrusts the running of the NHI and the major sources of financing to two quasi-public entities. The first is the National Health Insurance Service, and the second is the Health Insurance Review and Assessment Service. There's a graph under the regulatory section where you can see this. The NHI program is funded by payments and contributions from the insured, the government, and tobacco surcharges. The payments and contributions from the insured include employer insured and self-employed. For the employee insured contribution, a person must contribute 5.08% of their salary, which is split between the employer and the employee. For the self-employed, contributions are based upon the person's income. Self-employed contributions are calculated by a person's property, age, gender, and motor vehicles. There is reduced contribution for people in South Korea who live on islands and in rural areas. The government contributes 14% of the total annual projected revenue, and finally, tobacco surcharges include the other 6%. The medical aid program is jointly funded by central and local governments, which, as we described before, is an alternative welfare program for the poor, which covers roughly 3 to 4% of the South Korean population. The Ministry of Health and Welfare sets and annually modifies the criteria for beneficiaries. Recently, the government has faced financial difficulty in providing medical service for low-income people, and as a result has changed their system so that the NHI program now provides partial funding for the medical aid program. The final funding structure we will look at is the long-term care insurance. Long-term care is financed through contributions from three different components. First, it's paid for all those by the insured within the NHI scheme. Second, it's financed via government subsidies. And lastly, co-payments make up the third financial component for long-term care. More simply put, it's funded by contributions from both the public and the government. Currently, long-term care contribution rate is 4.78% of a person's NHI contribution, and the government finances 20% of the expected long-term care revenue every year. Co-payments from beneficiaries vary depending on the type of services used and the category of beneficiary. Now it's time to talk about the regulatory bodies. The Ministry of Health and Welfare has strategic oversight of the health service delivery in South Korea. The Ministry of Health and Welfare plays a central role in the regulation of health planning, policy formation, policy implementation at the national level, addressing key aspects of the health system, including financing, insurance, maternal education, child education, traditional medicine, mental health, and long-term care. The National Health Insurance Program outlines coverage and minimum standards for services and facilities. The Ministry of Health and Welfare directly manages several national hospitals and specialized corporatized public hospitals. It also implements various public health policies through collaborating with regional medical centers as well as health centers at municipal levels. Continuing on with the regulatory body section, the picture here depicts the breakdown of the regulation components in South Korea. The Ministry of Health and Welfare oversees the regional governments who are in charge of managing regional medical centers, and the regional governments can create their own plans to build and close hospitals for their residents, but need to consult with the Ministry of Health and Welfare first. Each municipality is in charge of managing health centers, health subcenters, and primary health care posts to ensure their residents have access to basic health services in areas where access is difficult. Municipal governments now can also make and implement plans to improve the health of their residents through health centers. Each municipality has one health center that provides various public health services. An interesting fact is that there are 34 regional medical centers directly under regional governments and 254 health centers accountable to the municipalities. And the regional governments and municipalities do not have authorities to raise extra revenues for health, other than local taxes and local revenue sharing from national taxes. The final component of BOEM's healthcare classification model is healthcare delivery. In South Korea, healthcare delivery relies heavily on the private providers. As of 2012, almost all clinics and about 90% of hospitals were privately owned. Some public health facilities provided medically necessary services at central, regional, and municipal levels. Primary care facilities and services are mostly privately owned and run by physicians and specialized in various areas. Secondary and tertiary institutions are the main providers of care, regardless if it is a primary level concern or higher. Patients have the freedom in their selecting their first primary contact provider, as well as choosing referred providers. Most acute psychiatric care is provided by private providers. Long-term care hospitals was initially introduced in 1994 to provide inpatient care not covered by the acute care hospitals or long-term care facilities. The main focus of long-term care is to treat chronic illnesses and care for patients at a post-acute stage, including those with dementia and disabilities. Long-term care insurances for the elderly cover medically necessary costs and services for physical activities or housework, including bathing, meals, cooking, laundry, cleaning, nursing, and shopping. NHI covers services provided by clinics, hospitals, pharmacy, traditional medicine, and rehabilitation. NHI covers traditional medicine and practices including acupuncture, moxibustion, cupping, 68 kinds of herbal medicine, 56 prescriptions, and 3 types of physical therapies. NHI outlines the coverage and minimum standards for services and facilities. Under the 1951 and 2009 Medical Act, secondary tertiary care is not for profit, though hospitals are often run like they are for profit institutions. Provisions for public health services is shared between the public and private sectors. Public providers of public health services include public health centers, which include the district and country, sub-centers, which is a sub-country, and posts, which is a village. Most public health centers provide preventative and promotive services, including immunization, management of tuberculosis, maternal and child health, screening and health checks, health education, and surveillance of communicable diseases. Health visit programs and community-based activities are also organized and implemented by public health centers. An issue for rural health is that 84% of service providers are institutions and are in urban areas. In our final section, we are going to discuss the health status of the nation that South Korea serves. This will include healthcare concerns of the South Korean population, to see if the healthcare needs are being met, and if there are any barriers and difficulties to the service provision. The healthcare concerns of the population being served in South Korea include high rates of smoking, suicide, and cerebrovascular accidents. We will first discuss smoking. Tobacco use is the leading cause of preventable illnesses and is responsible for more than 40,000 deaths annually in South Korea. In the early 1980s, it was estimated that 8 out of 10 Korean men smoke cigarettes. Smoking is culturally acceptable in Korea and is used as a means to relax, thus it is hard to reduce the smoking rates. Cigarettes are commonly viewed as something to be enjoyed, similar to an individual's preference for a favorite food, rather than a harmful product. The government and public health professions are trying to reduce tobacco use by implementing strong and effective tobacco control policies and measures such as tobacco tax increases and media campaigns. However, nearly 70% of smokers in South Korea say that they are still smoking because smoking has become their habit. The second healthcare concern we're going to be talking about is suicide. Suicide is the leading cause of death in South Korea. Culturally, this is often related to high stress and low societal support. An excessive competition-oriented educational environment, sudden changes in socially cultural values, and the introduction of foreign cultures all contribute to high depression rates in South Korea. The Ministry of Health and Social Affairs does ensure that hospitals have psychiatric wards and ensures there are adequate mental health institutions. However, culturally, depression is viewed as shameful, which prevents individuals from getting the treatment they need. As this chart shows, there is a growing prevalence of suicide in males and females in South Korea, especially in the males 60 years and older. Another healthcare concern in South Korea is stroke. Stroke is the cause of 12.35% of deaths in South Korea. The rate of cerebral vascular accidents in Korea is related to the high rates of smoking, stress, depression, and a large amount of consumption of meat in their diet. The government is quite worried about the future economic burden of the Korean community imposed by stroke. Thus, the Ministry of Health and Welfare in South Korea is creating initiatives to decrease the disability and mortality related to strokes. Are the healthcare needs being met in South Korea? Yes or no? Yes, the healthcare needs are being met in South Korea because a wide range of services are provided and covered under insurance. South Korean people are overall happy with their healthcare system. People in South Korea have among the highest life expectancy in the world, which demonstrates the effectiveness of their healthcare system. As well, people have great access to healthcare, as hospitals are more likely to have hospital beds available and access to cutting-edge medical technologies. However, there are also many flaws in their healthcare system. Low-income individuals with multiple chronic conditions who are not enrolled in the NHI program are often underserviced. Unfortunately, some common conditions are also not covered by their insurance. Also, there is a lack of long-term care beds, which leads Korean patients to remain in hospitals for over twice as long as compared to other countries on average. A major concern is that the Korean healthcare system has a continuous expansion of acute care services that is not able to adequately deal with the rapidly expanding aging population as well as the rise of chronic diseases. The final topic we will address are the barriers and difficulties to service provision in South Korea. One of the barriers is regional inequalities, such as the lack of access to medical care services for those living in rural compared to urban areas, Over 90% of physicians and hospital beds are in urban areas. As well, issues of distributional equity regarding healthcare resources exist. Another barrier is the increasing use of healthcare services and their aging population, which have placed a heavy pressure on the NHI. Also, primary care services lack a framework that ensures comprehensive, continuous, and coordinated care, such as a mandatory referral system. Policymakers are struggling to prioritize quality of care over other objectives in this ongoing and rapid period of change. Also, there are issues with hospitals and clinics as they must meet the minimum requirements to get established, but thereafter are autonomous and have little government oversight. One more issue is that there is an imbalance in premium rate between employed and self employed contributions to the NHI due to difficulties in monitoring citizen income. Thanks for taking 20 minutes of your time to watch our video on South Korea's healthcare system. Have a great day.